Great to be here, and also to follow these great talks. Really enjoyed that, Dr. Jones. My job is, I think, relatively easy because this has all really set the stage nicely. How you look at knowledge, whether it provokes anxiety or it empowers you, has a lot to do with language, and I hope I'll be expanding your understanding of genetic language here. And both James and Stefan already set the stage here nicely. So just briefly, disclosures. I'm PI of various gene therapy trials. I'm also, importantly for this talk, founder of Swan Biotherapeutics. So most of you already know about this, but just as to set the stage again, adrenoleukodystrophy, a single gene disorder caused by mutations in ABCD1. This is important as we talk about gene therapy. For adrenomyeloneuropathy, ABCD1 encodes a peroxisomal half-transporter that sits inside the peroxisome and needs to transport very long-chain fatty acids into that peroxisome for degradation. There are various different phenotypes that you've heard about in the course of this meeting. But here for this talk, important that the most common phenotype is adrenomyeloneuropathy. So a long word. What does adrenomyeloneuropathy mean? It's an adult onset non-inflammatory axonopathy of the spinal cord, and it affects mainly two tracts. One tract that brings information from the periphery, from the muscles, from your joints, up through the spinal cord to the brain, and another set of tracts that brings information from the brain down through the spinal cord to your muscles, sends motor signals down to those muscles. And both of these tracts are important and affected in AMN. And these being the longest tracts of the nervous system, this has always been a challenge in the field, how to remedy these tracts and enable good transduction of information to get either up to the brain or from the brain down into the periphery. Different than cerebral ALD in boys, there's no blood-brain barrier disruption, making it more difficult to deliver to this system in the spinal cord. So we've now heard about the gene, its function, the tracts that we're trying to remedy in AMN. The actual gene encodes a protein called adrenoleukodystrophy protein, or ABCD1. This is, as I said before, a half-transporter. It either needs to couple or partner with another one of these half-transporters or couple with another family member in order to accomplish transport of those very long-chain fatty acids into the peroxisome. Importantly, ABCD1, this protein, is expressed in brain in certain cell types, in astrocytes, in microglia, oligodendrocytes, and only a few neurons. So just keep that in mind as we're thinking about targeting different parts of the nervous system and brain. Okay, you heard from James already very nicely a summary this morning of different trials that are ongoing in leukodystrophies and in the gene therapy space. I just want to point out again, in terms of over time, the community and patients learning about different modalities here. Gene therapy is not gene therapy. There are different kinds of approaches. There's either an in vivo gene therapy approach, which is AAV mediated, which is a direct delivery of a transgene in a virus, or there's a cell-based delivery that we call ex vivo gene therapy, a lentiviral approach. And this is what has been employed in boys with childhood cerebral ALD, okay? You harvest cells from the bone marrow, you transfect them in a dish, delivering a healthy copy of the gene, you deliver those cells back. What I will be focusing on today is the AAV gene therapy approach. Okay, a little history of gene therapy overall. this has been a long time in the making for the past 50 years. Originally, various AAV vectors discovered and cloned, and then first human retroviral cell-based applications being performed. And then in the past 10, 20 years, really sort of a revolution of insights and human trials. First human neurodegenerative diseases treated not just for childhood cerebral ALD, but also then seeing the success for spinal muscular atrophy with an AAV-based approach, and then also for retinal diseases, various treatments approved by FDA and EMA. So what kinds of different viruses do we use for gene therapy? Again, a class difference between the ex vivo cell-based approach that uses a lentiviral vector, which is a large RNA virus, as opposed to what we use for the direct in vivo delivery, an AAV, which is a small DNA parvovirus. Why is that important? As you learn about these different kinds of vectors, you have to understand size matters here, because if your gene is too large, you can't fit it into an AAV. There are ways you can save space and cut down, but if your gene is too large, you might have to go to a lentivirus. And then there are, of course, also differences in delivery. With the AAV approach, you can deliver directly. You might be able to save time, as opposed to what happens with the ex vivo lentiviral approach, where you're delivering cells that have to first home to bone marrow and go from bone marrow to blood and from blood to brain. So that takes time. So about 5 to 10 years ago, we were watching with fascination what was happening in the field of spinal muscular atrophy. As some of you might know, this is a disorder quite devastating to infants that was affecting the lower motor neuron. And these infants were being successfully treated by AAV9 gene therapy here by Brian Kaspar and Jerry Mendel. And it was quite revolutionary to watch this devastating disorder be successfully treated. So why were we interested in this? The reason is that the lower motor neuron is also a spinal cord target and sits right here in the spinal cord adjacent to the structures that are affected in adrenomyeloneuropathy. So in adrenomyeloneuropathy, as I mentioned before, it's the corticospinal tract that brings information down to the muscles, and dorsal columns that brings information up from the periphery to the brain. And these tracts sit right next to that lower motor neuron affected in SMA. So the thinking was, if this works for SMA, maybe we can do something similar for AMN. And here are some of the early successes in SMA, where they were showing that these children that were never able to sit up, stand, walk, were now making tremendous strides, walking, running, doing things that had never been seen before. So efficacy was there for SMA, but there was also the recognition that AAV gene therapy came with some side effects. At least in animals, there was a recognition that dorsal root ganglion, a structure next to the spinal cord, could show some inflammation. And also liver histology in animals was concerning for inflammation. And this can occur in humans as well, as shown here in some experiences with ALS patients where AAV gene therapy was employed. Here a study from UMass that showed that inflammation in the dorsal root ganglion was quite significant, but also that the patient in red who suffered from that inflammation in the dorsal root ganglion, that could be prevented in a second patient by using immune modulation and immune suppression. So again, a treatment that works, that has efficacy, but also comes with risks, and those risks need to be properly managed with steroids and other immune modulation. So after seeing what was happening in SMA, we decided to package ABCD1 into an AAV vector, and specifically an AAV9 vector, and deliver this to the mouse model of ALD First, we looked in mixed glial cell cultures. We saw that we could deliver into the right compartment of the cell, into the peroxisome. We could lower very long-chain fatty acids. And when we delivered this to the mice, we could either by delivery into the ventricles or intravenously also show functional degradation of very long-chain fatty acids. We went further to develop an intrathecal osmotic pump approach. So we inserted a pump here around lumbar region L4, L5 in the mice, and we're able to optimize that delivery to spinal cord, thereby also reducing leakage into the systemic circulation. Did this work? And I show here everything that's green is transduction and delivery of the gene to the spinal cord, and you can see that you get nice delivery in a dose-dependent manner. As you increase dose, there's more green, and you get into the right cell types that usually express ABCD1. I told you before, these are glial cells, astrocytes, and microglial cells. Less so, but particularly you get into also some neurons that will tell you are important here. And you can see that this works actually much better compared to bone marrow transplant in the mice. You get much better delivery to the spinal cord with this AAV9 approach. Just to show you here also some of the cell types that are transfected. We did this in multiple studies to prove that we could deliver into the right cell types. So why the intrathecal pump, and does this targeting actually matter? What we really wanted to show is that we could not only get nicely to the spinal cord and the dorsal root ganglion, but also avoid delivery to liver and heart. And when you deliver intravenously, you see a lot of protein expression in heart, but if you deliver with an intrathecal pump, there is hardly any expression in heart, while there is very nice expression in the spinal cord. So last part of this story in mice, you see that the mice that get delivery of this gene therapy at 5 months, but importantly also at 12 months when they're quite symptomatic, have an improvement in their hind limb clasping. Mice with a faulty ABCD1 gene actually show a lot of spasticity and contractures around 1 to 2 years of age. So just briefly speaking on the sensory pathology in AMN, I showed you the structures that are so vulnerable are here in the spinal cord, in the back of the spinal cord, and on the side structures that are bringing information up to the brain or down from the brain. And we want to really be very careful about these structures because we know these are where a lot of human ABCD1 is expressed. Johannes Berger and Vienna showed very nicely that few of those neurons that express ABCD1 sit right in this structure, and we think that these are critical as they're transmitting information up to the brain. They're a little bit of a hub for sensory information that's so critical in AMN. So how can we separate this from potential AAV-mediated toxicity? So I think as we will be embarking here on an AMN gene therapy trial, it'll be important to understand the structure, and we've been spending a lot of time looking at this in mice and knowing also that mice with lacking ABCD1 develop a sensory phenotype and have heightened pain. And we have a fancy term in medicine for that. It's called mechanical allodynia. And we've also understood a little bit of the mechanosensitive channels that are important here in these DRG structures. So just to now move to humans and how we are designing studies and trials to impact AMN patients, knowing that these DRG channels are important, knowing that all that sensory information coming up from the periphery to the brain is critical, and that this hub of the DRG is critical to measure outcomes around wonderful work coming out of Amsterdam using force plates and also wearable devices to measure balance and understand the critical aspects of proprioception and balance as this creates fall risk. And we have also been studying various conditions where we can understand what patients with AMN are going through as they are facing circumstances that might put them at fall risk. So in parallel to the gene therapy study that is about to embark, we've been conducting an AMN natural history study called SIGNET. The challenge here is to show that we can perform not only in-person visits, but also remote visits in the home setting using wearable devices and sensors. In this case, there are sensors around the lumbar area as well as on the feet that allow us to measure timed tasks and show that these functional tasks like time from sit to stand or 2-minute walk tests can be measured remotely, thereby really allowing us to assess over a 1-2 year period what is happening in AMN. And so far we've enrolled 65 patients, about a third of them having reached the 1-year mark. And I think this is a very nice setup for our gene therapy trial that excitingly is just started at UMass in Worcester. Similar to what I just described in mice, this is an intrathecal approach using a pump with slow delivery to the lumbar intrathecal space, thereby targeting these long structures in the spinal cord that I mentioned before. This is a study being conducted by Dr. Gazemi and Dr. Brown at UMass. And as I mentioned before, it's a single intrathecal administration over 5 to 7 hours, and the patients should ambulate during the infusion. So different than some of the bolus administrations that you've heard about in the past, and also different from the intravenous or systemic administration in other studies like I reported yesterday for Kahneman disease. The advantage here is we expect less systemic leakage, less immune responses because this is limited to the intrathecal space. So the key inclusion-exclusion criteria for this phase 1/2 study, men ages 18 to 65 can participate. They have to have the genetic diagnosis of AMN, and they have to have a myelopathy of mild to moderate severity. It means they have to be, in this first study, their disability has to be minimal to moderate, so they cannot be fully dependent on walking ambulation. And there's a lot more that you'll hear from Eileen Sawyer this afternoon. So just to conclude here, for successful AMN gene therapy, I hope I've shown you that targeting the right structures, getting into the right compartment, getting to those long tracks that are so troubling in AMN is critical, understanding what cell types need to be targeted, and that we luckily have AAV capsids that can accomplish that can also be delivered into that intrathecal space. We understand from other trials that we can use immune suppression, immune modulation to suppress immune responses. We think that the dorsal root ganglia are critical structures because of the amount of ABCD1 usually expressed there. And we are starting to understand more about how these dorsal root ganglion neurons mediate neuronal dysfunction, pain, spasticity, sensory aspects. And the first trials of AAV have just started. The gene therapy study in AMN is called PROPEL. The parallel AMN natural history study is called SIGNET. So glad to take any questions. I hope I've stayed on time. Too many people to acknowledge, but I hope I've done that along the way. Thanks, Karen.